Anybody here that's done proton treatment with space ore gel? Anybody? We've got a couple of guys that, you have done space ore? You have? Okay. Raise your hand, Jim.
Explain proton treatment.
Huh?
Explain proton treatment. I never heard of
Explain. If you don't know what it is, you haven't had it.
That's right. It's a gel injection that helps protect your rectum and bladder during the treatment. Nobody's really done it, right? Larry, perhaps do you know, I heard one guy suggest that it is paid by insurance, and I think you indicated.
Yes, it is. Medicare will pay for it.
Medicare will pay for it now. So that's good. Somebody else asked me.
Yeah, I saw that report.
Yeah, okay, great. Wellington Sue wants to know anybody that knows about brachy at UCLA, if you've done it. You have not done it. I think he's researched it as well. Nobody else has done it yet. Okay.
Comment?
Huh?
They're not doing brachytherapy at UCLA. They're doing high-dose radiation, which is similar to this.
Okay. More confusion.
It's a type of brachy.
Yeah. Okay. Enough confusion. Okay.
Jane? Yeah, I am considering space ore. I spoke to you on the phone about it.
Yeah, right.
Yeah, if there's anyone else in the group considering it, I'd like to talk to them.
Yeah, there's a couple of people are considering that there's two more over there.
Okay, great.
Look at each other and talk about it after the meeting.
Thank you.
Okay? So let's get rolling here. Quite obviously, I'm not George Johnson. He's 5 inches taller than me, so it can't be him. He's cruising Scandinavia, so hopefully he's having a wonderful trip. So we'll get on with it. We want to thank the people who allow us to use this facility free of charge, and let you know all the people that are involved in making this thing work as well as it does. It's probably one of the best in California, if not the nation, from the standpoint of size and effectiveness. We have in our membership roster some 850 guys now, so that's a lot. Lyle isn't here today. I'm the second guy down the list. George, I just mentioned. Bill Manning, back there hiding behind the camera. Videographer. John Tassi, where are you hiding now? Back up there in the corner. He handles our website and doing a great job with that. Steve, raise your hand, took over the newsletter, doing a good job for us. Thank you for your work. Bill Lewis writes the summary that goes into the newsletter, also doing a great job for us. Takes a lot of time to do these things, doesn't it, guys? Yeah, okay. Bill Bailey, where's Bill Bailey? Bill Bailey is here. He runs the library for us. Chuck Grimm. Frank, why can't I find you? You're there. He sets up the thing in the morning for us. And Jim Kilduff is our greeter out there with a smile every day, right? Everybody's a volunteer, so any of you that think you can help us along, we'd appreciate any help you can give us. In that instance, George is now 85, I'll soon be 80, and Lyle LaRoche is a year behind me, so we're going to have to really put some effort in to changing that cadre here, if you will. Okay, all you newcomers, were you given a package of information that includes a yellow sheet? Okay, it has an information kit with it, and turn that yellow form into either to Jim or leave it here at the speaker stand, and I give each one of you a call the beginning of the week so that I can talk about your specific situation to help you along, hopefully. This is our purpose. We share patient-focused experience on becoming your own case manager through informing, networking, and caring. The issue with today's MO is that doctors just don't have that much time to spend with you, to work with you, to figure out what may be the best thing for you. So you need to learn as much as you can about what you'd like to do, and then maybe they can help you along the path. We are not medical professionals, but we're a group of experienced participants, and any sharing by anyone at this meeting shouldn't be a substitute for your medical counsel. I mentioned our website, ipcsg.org, lots of good information on that, including a tab there for personal experiences, including mine and a lot of others, to find out what the treatments guys have chosen and the path that they've gone through. We have the library you can see down here. It has very many important books, one of which I've mentioned a couple times is Key to Prostate Cancer by Mark Schultz and 30 other doctors, recently published, so it's available there. It's really informative. And I just received the mid-conference DVD from Prostate Oncology Specialist, which is available for checkout only. There's another copy over there. We mentioned we did do the newsletter, which brings us a lot of good information. We have an outreach group, which is basically George and myself and Lyle at times, to go to men's clubs or whatever and try to get involvement to reach out to men who really need to be made to understand they need to do something like PSA testing to get going. That's changing a little bit now that now doctors will do the PSA test and will help you decide if you want to do it or not. And you should, of course. And tell all your friends and neighbors to take care of themselves by doing a physical and asking for the PSA test. Fortunate thing is that statistics show me that the best outreach effort we have is you people bringing friends to these meetings. We do some advertising that's quite expensive, but it in no way comes up to the amount of people that get here because of friends. We do monthly meetings on the second Saturday of every month. I think we now have speakers lined up through the end of the year. Next speaker is going to be Dr. Kipper. You can see the subject there, when cancer returns, how soon can we find it? Dr. Kipper helped me find my metastasis, and I got it blasted and took care of that part of it, but we just have to keep going after it. Okay, I'm going to do some quick surveys here that may be of interest to the doctor and to especially newcomers. And how many are here for the first time? Let's see your hands. 2, 3, 4, 5, 6, 7. Okay. Of those, how many came here because you saw our ad? Just one. That kind of proves my point that maybe that's something we need to reconsider. How many have been recently diagnosed? Raise your hand. Quite a few. That's good. Glad to know that. I'm not glad you have the issue, but I'm glad that you're coming to see us. How many have had prostate cancer for up to 1 year? A few. Okay, a few. Up to 4 years. This is going to be getting better as we go. Okay, all right. 5 to 10 years. Look at this. All right, okay. It's not something that is going to get you really quickly. 11 to 15 years. Okay, quite a few. Higher than that. I've got 16 years.
17.
17? What else? Okay, our guy that's got 25 years isn't here today, so we have some good seniority in that area. So it's not a disease that you have to fear on a near-term basis. How many of you that are here are doing active surveillance as your initial treatment, not after having treatment? This is getting more and more attention now, and you want to do that as long as you can. How many have had surgery? Okay. Of those, are all of you recurring? Well, this is true of any of these I'm going to ask about. How many did radiation, have done radiation of any kind? So that seems to be most popular. And again, the same question, of those that have done it, how many are here because you're starting to recur from it? Okay. So the point being that whatever you choose, you have to do, let's call it active surveillance, to make sure that you're staying on top of it, because it's something that may come back on you. Mine's come on me 3 times now, with different treatments, 4 times. How many have done chemotherapy or are undergoing chemo?
Missed ADT.
Oh my goodness, that'll be everybody. ADT. Oops. How many are doing ADT? Which is hormone therapy, if you're not familiar with the initials. Okay. And now back to the chemo, sorry. Thank you for monitoring me, Bill. I need help. I need all kinds of help. Okay. A lot of new treatments that some have done. How many have done the Provenge treatment? That's me. That's a boost of your immune system to help you deal with the disease. That's me. Zofigo, which is an injection of radium-223 that helps, goes directly to any mets in the bones to help clear that. I've done that. You've done that. And it was very effective for me. It cleaned out almost everything but one tiny spot, which I had zapped. There's a new one called LUPSMA, which is, I know Danny there's got it. You're doing it, and I'm trying to get into the study. Okay. Well, this is probably redundant. How many are here because you're experiencing recurrence? Yeah. Okay. How many are undecided? What do I do now? Okay. All right, enough of that. Here we go, guys. We need your support to help us going. All donations are tax exempt, and we have no medical or religious affiliation. So, guys, please pass the baskets. We thought about using wheelbarrows, but it didn't help much. But anything with zeros on it, we like a lot. But it helps the organization a great deal with what we collect here. These notes here, I'm not going to go into it in depth today because we've got the speaker here, but help you manage your own case. Early detection PSA test is definitely a must. Nowadays we're talking about high definition diagnostics, and Dr. Kipper is going to talk about some of that. Targeted biopsies as opposed to shot in the dark, if you will. Always know your Gleason score because you'll get asked about that many times. And keep in mind, if you got the low Gleason, like a 3.3, consider active surveillance. And one of the most difficult things we all have to do is treatment selection, because there's unfortunately not yet enough genetic information available that helps us decide which is going to be the best treatment for us. The only one I'm personally knowledgeable of is, I recently did a test because I've been on Xtandi for like 3.5 years, and I'm starting to resist that, but I did a blood test that let me know whether or not I could switch to Zytiga, and it came out negative, which means that I could switch. But I'm going to try the LUPSMA study first. Okay. Here we got the main man here. I'm going to introduce Mark Schechter. He's a board-certified diagnostic radiologist and fellowship-trained interventional radiologist. He received a medical degree from Pennsylvania State University College of Medicine at Hershey Medical Center. He completed his diagnostic radiology residency and interventional, boy, these are big words, interventional radiology fellowship at UCLA. And Dr. Schechter joined imaging healthcare specialists in 1984 and has had several leadership positions, including Chief of Radiology at Scripps Mercy Hospital and President of Radiology Medical Group. Please welcome him. I've seen him twice. Okay. Okay, you get him set up now.
Yeah.
Let me get my cane, get out of the way.
Okay, well, thank you for inviting me. Gene, you're very informed. I'm impressed. So I'm Mark Schechter. I'm an unusual interventional radiologist. When I came out in 1983-84, radiologists did everything. So my motto is never give up what you've gained. So when I came out, I was a body imager with a fellowship in interventional radiology, but I did nuclear medicine back in those days. I never gave it up. Being an interventional radiologist, I deal a lot with cancer, putting tubes in patients, doing a lot of biopsies, et cetera, et cetera. And PET-CT became a natural for me, 15 years ago, because it's cancer, it's oncology imaging, of which PET-CT and nuclear medicine is a big part of. So became natural for me as an interventional radiologist to do PET-CT and nuclear medicine. There's not many of us around. Most younger interventional radiologists like to just do interventional radiology. I like doing it all because you never know what you're going to end up doing when you come out of training. Because 1983, 84, this stuff wasn't around. So it's been a pleasure. Name is Schechter. If you're of German heritage, it's an easy name. A lot of patients butcher it. So I usually say, I'm Dr. Schechter, rhymes with Hector. The problem is they come away thinking my name is Hector Schechter. So I have to be careful which analogy I use. All right, so complicated topic. Oh, and by the way, I am partners and colleagues in my medical group with Ross Schwartzberg, who is here, I think, late 2017. Amazing MRI.
Last month.
Oh, was he here last month? Amazing expert in MRI. He's done probably 1,500 MRI scans, diagnostic, staging, whatever. And he's doing fine work. My other partner, James Cooper, was he here? James is a hybrid. He's halfway between me and Ross. I help James doing targeted MRI-guided biopsies. He doesn't do the diagnostic stuff I do, but I kind of straddle both worlds, and I'm proud to be associated with them. When's the last time you had a radiation oncologist here? Doctors that do radiosurgery, do external beam radiation therapy, are involved in proton therapy. Have you ever had one?
I've seen Dr. Rossi, Dr. Munt and his group.
Shirazi?
Rossi.
Rossi?
Rossi is protons.
Okay. How about non-proton therapy radiation?
Dr. A.J. Munt.
Okay, I don't.
Rose, Dr. Rose.
Okay, good. When was the last time they were here?
January.
Okay, great. So I'm not gonna, treatment is above my pay grade. I'm a diagnosis guy and a biopsy guy. But I'm happy to hear that you've had radiation folks here because treatment options are all over the place and very complicated. And there's some great and much better options now than used to exist. So my job is to talk about diagnostic imaging. And this is basically the menu for diagnostic imaging. First talk about X-ray. X-ray has very limited use in the detection of prostate cancer. Where it comes into prostate cancer is with incidental findings usually. This is a normal lumbar spine x-ray. Whoops, I'm sorry. Too much coffee. Okay. So if we were to see a white lesion or a sclerotic lesion, it would be an incidental finding, and then that would trigger investigation and evaluation to find a primary cancer. Prostate cancer is a common source, but lung cancer, bladder cancer, other types of cancers. But in general, x-ray is of limited usefulness. Ultrasound of limited usefulness with prostate cancer. I was doing transrectal prostate ultrasound in the 80s, early 90s. There's one urologist in town that was the first in the 80s. My group was the second. And we thought it was a pretty good test. Well, it turns out that, I don't know the percentage, but at least 50% of prostate cancers you cannot see with transrectal ultrasound. So it's a very good test to measure gland volume because we image the prostate in 3 dimensions and can do a volume calculation. It's also a good way to do transrectal ultrasound guided biopsy, but unfortunately, most of the time, it's a blind biopsy, multiple, but I mean, many of you probably have had it, and there's a lot of great advances in this topic that you probably heard from Dr. Cooper and Dr. Schwartzberg. So again, we call these isoechoic cancers, meaning that, so here's the transitional zone and this is the peripheral zone, meaning that cancers are often equal in appearance to background, or isoechoic. The limited value. CT, for those patients who cannot undergo MRI scanning for various reasons, severe pain, severe claustrophobia, pacemakers, although they're developing MRI compatible pacemakers and have developed them, aneurysm clips that are ferromagnetic, aneurysm clips in the brain. Probably in the last 10 years, virtually all neurosurgeons use non-ferromagnetic aneurysm clips, and those patients can have an MRI. And I won't get into all the other devices like IVC filters and coronary artery stents, on and on. CT, if you need to stage somebody, well, let me back up. First of all, CT, here's the prostate gland. You just can't detect prostate cancers on CT, either without contrast or with IV contrast. But in a patient with a known diagnosis, it's a very good test for staging somebody because you get a chest, abdomen, pelvis, and you look for pulmonary nodules. And by the way, patients with low Gleason scores that are not high-risk patients generally don't get, extensive CT scanning. But, sometimes they get bone scans, and if they can't have an MRI, they'll get a CT scan. CT is good to look at the bones, and it's good to look at lymph nodes. But it is not good to detect cancer. It's a staging test to look for cancer outside the prostate gland. So many of you have probably had a CT. It's basically a volume of tissue, and we basically slice the patient into very thin slices, 5 millimeter thick, as low as 1 or 2 millimeters thick, and we look at the bones, soft tissues, lymph nodes. And every now and then we pick up incidental findings. This is a big abdominal aortic aneurysm. The aorta should be more like this. This one's probably approaching 3 inches in diameter. So occasionally we'll pick up incidental findings. Also, CT is great for CT-guided needle biopsies. Say a patient has a suspicious node, and I'll show you some examples. If a patient needs a bone biopsy or a lymph node biopsy, it's done by an interventional radiologist, and CT guidance is a great way to do it. And I think I have a case or two. MRI, as you know from Dr. Schwartzberg, is now becoming an amazing tool for diagnosing, staging, both pretreatment and then evaluating recurrence. The signal to noise ratio, the spatial resolution, it's just the best we have in terms of those factors. Limitations are, some patients can't have the scan, and the scan is really only of the pelvis, so you're not evaluating anything above the pelvis. So you can't see lymph nodes that are higher or more distant. But for local evaluation, great tool. And we also use it for needle biopsy. So this is I mean, I don't want to get into, because I'm not an MRI expert, but you know, I've evaluated many MRIs and I've performed many biopsies. So here's a typical cancer of the left peripheral zone. The peripheral zone is this blue area. This is a diagnostic MRI scan, one slice that's been run through computer-assisted diagnosis, fancy computer algorithms that reconstruct and look specifically at perfusion and increased vascularity. Tumors tend to be more vascular. You won't see this on a regular MRI, but well, you might see it, but this is a great way to further localize and to increase diagnostic accuracy. And so this same patient, obviously many of you have heard talks about biopsy, but I noticed there were several folks that are new to this forum. So we have the bladder, which on MRI, the urine is white. Here's the prostate gland, and here's the cancer in the left peripheral zone. This is a guide that's placed into the rectum. This image has been flipped because you're face down. You obviously can't do a transrectal biopsy when the patient is face up, so I inverted this image. And we actually put the needle in, and then before we fire the needle, this is just, I mean, we take multiple course, but this is a great example of how accurate a targeted, an MRI-assisted targeted biopsy is. Okay, nuclear medicine. And when I say nuclear medicine, I mean conventional nuclear medicine, not molecular imaging, also known as PET scanning. Technically, PET scan is a form of nuclear medicine. So nuclear medicine, again, divided into conventional nuclear medicine and what we call molecular imaging, although bone scans are molecular imaging to some extent. Molecular imaging exams are also known as PET scans. So back to conventional nuclear medicine, the definition of any type of nuclear medicine scan is we take a radioisotope, and there's many of them, but with bone scans, technetium is probably the most widely used radioisotope, and it is radioactivity, but it's incredibly minute, and it's cleared from the body in 24 hours, but the amount of radiation the patient gets is trivial. And I apologize, I guess my thumb, I'm not a big guy, but my thumb must be huge. So we take the radioisotope and we marry it to any other substance. And the substance that we select is designed to target an organ. So with bone scans, you take technetium and you marry it to a small amount of phosphate, because phosphate is a building block for all bones. Calcium and phosphate are constantly being absorbed and rejected by bone. It's normal bone turnover. Bone is a living organ. But we can also target the thyroid gland by injecting radioactive iodine. We can target the liver and the gallbladder by using agents that are excreted in the liver. But my comments are just with bone scans. So we have many different isotopes. This is a form of prostate cancer staging, either initially or later. And we're only looking at the bones with this type of scan. So this is a typical whole body bone scan. In addition to a whole body bone scan where we, and by the way, we inject the patient, they come back in 3 hours. A lot of you have undergone a bone scan. We inject a little radioisotope, come back in 3 hours, you lay on a table, and the camera is recording gamma radiation that's coming from your body. So we call this an emission type of scan, just like a PET scan is. The radioactivity is inside your body, in this case bones, and the radiation is coming out. And we have a camera that measures the level of activity, and the computer reconstructs where it is. So that's a simple physics lesson on this stuff. So technetium is married to a phosphate agent, and we scan the patient. Probably takes 20 minutes to record activity from the entire skeleton. This is the anterior view, so you can imagine the patient's laying on their back. This is a posterior view where we're imaging all the posterior structures. So the sternum, the anterior ribs, the bladder, which is where the body excretes the technetium, are all easily seen. You flip the patient over, you don't really flip the patient over, it's the scan that's taken the posterior image. Now all the posterior bony structures are imaged. The posterior ribs, the scapulae, the spine, the posterior pelvis, and again we see the bladder, and these are both normal. A bone scan is very sensitive, which means if disease is there, how good is it at picking up disease? So we want a high sensitivity. The problem with bone scans, it's not a problem, but a feature of bone scans is that it's not necessarily very specific. You can have a hot spot, but the question is what's causing the hot spot. To get a hot spot, it means that there's increased bone turnover at that location. So whatever is causing increased bone turnover, increased bone metabolism will be hot on a bone scan. So tumor can do it, metastatic prostate cancer can do it, a fracture can be positive for a year or more, any infection, osteomyelitis, will be hot on a bone scan, and arthritis will be hot on a bone scan. Virtually every patient over the age of 60 has hot acromioclavicular joints or AC joints. And so this is a nice example of arthritis. So this, unfortunately, is a patient with widespread skeletal metastatic disease. Now, it doesn't really matter. I mean, to have stage 4 prostate cancer, you just need disease in one bony location, often biopsy proven. So this patient has extensive disease, but it's still stage 4 disease. So it's hard to see even normal bone, but you know, these ribs are near normal. The head of the humerus is near normal, but every hot spot you see is metastatic prostate cancer. To make things confusing, there's a PET scan version of bone scans. And many of you, I know Gene has had this scan, many of you have had a PET bone scan. And there's an agent called sodium fluoride that goes to bones just like phosphate goes to bones with a conventional bone scan. The nice thing about the sodium fluoride scan, I think you can immediately see the images are a little sharper, there's better spatial resolution, and the signal to noise ratio is much greater. You also don't have to wait 3 hours to be scanned. You're injected, again with a low dose, and this is fluorine 18, so it's a PET agent, not technetium, which is a gamma emitter. Sorry about that. But a gamma emitter is low energy. PET scan agents like fluorine 18, choline 11, on and we're going to talk about that, are high energy events, positron events. So you don't have to wait but 30 minutes to get a sodium fluoride scan. So this is a very sensitive exam. It tends to pick up more lesions than bone scans. And because we do a CT along with it, the specificity is really increased. So this patient has a hot spot in the 5, 4, 3, 2, L1 vertebral body, has a hot spot in the right hip joint, right in the weight-bearing portion of the hip joint, and the CT that the patient had at the same time as the bone scan, the PET bone scan, now we have great specificity so that we can say this hot spot is a benign compression fracture, and this hot spot is osteoarthritis. This is the normal left hip, and this is the abnormal right hip. You can see that joint space is narrowed and there's a bone spur there. So we can say, for those who understand statistics, this test has a very high negative predictive value, meaning that if we call a sodium fluoride or a bone scan negative, that means there's a very high likelihood that you are right. A sodium fluoride PET CT, if it's benign for metastatic disease, it's virtually 100% likely that that conclusion is correct. Any of you have had a sodium fluoride bone scan? Okay, great.
You have to pay for it now, by the way.
Right, that's in the next slide, and I'll get to that. It's very unfortunate.
Sorry about that.
No, not at all. It gives us food for thought. Okay, now we're into the last major part of the talk. We're talking about PET now. So PET stands for positron emission tomography. Positron is a high energy event, probably 5 times the energy as a gamma event, which is conventional bone scan. Positrons, you get 2 high energy positrons that result from a collision and go out at 180 degrees. And again, you're in a PET CT. It looks like a CT scanner. It looks like an MRI scanner. But what it is you have a PET scanner, which is a big camera that circles the patient, and we fuse a CT scanner to it. So a CT scanner is probably this wide. A PET CT is about twice that wide. So a patient has a CT scan first, a whole body CT, patient's just breathing gently. It's not a diagnostic CT. All of you who have had a diagnostic CT, take a breath in, hold it, the table moves, that's the scan, okay? The CT part of a PET CT is done so that we can improve the appearance of the PET images, eliminate artifacts, make it more accurate, and tell the computer where that positron emission is happening in a 3-dimensional manner. Right? That's about the simplest way I can explain it. PET agents, again, these are radiopharmaceuticals, just like a bone scan or a thyroid scan or a liver scan, are taken up by all tissues, the brain, the bone, mediastinum, the liver, spleen, lymph nodes, on and on and on. And it's a metabolic imaging test. Tissues that are more hypermetabolic are hot. Tissues that are normal have a kind of a low level activity. Tissues that are fluid or have no solid tissues are actually have no activity. The importance of that statement is that things like sarcoidosis, osteomyelitis, lung infection, pneumonia can all be hot. So the reason we do the CT, it helps us decide and identify which PET positive lesions are not cancer. So the CT part is very important. So CT and MRI are morphologic scanning. We're looking for lesion size, lesion appearance. We're looking at the morphology or the anatomic appearance of that particular region. A PET scan is a metabolic scan. It gives us the metabolic activity of that particular tissue, and it's extremely powerful and ideal for staging cancer. Because like this example shows, that's a normal-sized lymph node. We're above the prostate gland. This is the bony pelvis, because it's white. These are the psoas muscles, so they're kind of intermediate density. Everything that's black is bowel, because air is not dense. So on a CT scanner, it's an X-ray, but it only measures density. So air is black, muscle is gray, bone, being the densest organ in the body, is white. This lymph node is near the iliac artery, and this is not a pathologic node. It's about 5 millimeters, which is, I don't know, 3/8 of an inch. I would have to do the calculation. But on a PET CT scan, this actually was a PSMA scan, and I'll get into that a little bit. This node is hot, so we know usually it could be infection or a reactive node if the patient has had radiation or any other sort of therapy. But this is highly suspicious for a pathologic node. Usually the PSA is elevated, and I can't get to it. I'll show you a couple cases where I biopsied an iliac node, but I cannot get to this node with a needle, and I would do it with CT guidance. Well, I'm denied here because of the bone. I can't come anterior because I would hit the bowel, and I can't come posterior again because of bone. So the only way to confirm the diagnosis would be surgery, which nobody would do because that's way overkill. So in the right clinical context, elevated PSA, the status of the prostate gland, is it there, is it not, is there other disease, et cetera, et cetera. One outcome might be that the radiation therapist, extends the field and includes this in their treatment field. But this is a great example of morphology, lesion size versus metabolic activity. That's what PET's all about. It's a metabolic imaging test. Okay, so this would take 3 hours to talk about. These are all of the available PET agents, and again, these are all metabolic agents. They're all radioactive. I don't know what the proton number on the periodic table is for copper. I think that's copper, but it's not 64. The normal one, the non-radioactive one, I'll just throw it out, it's 62. The isomer, that's 64, is a PET agent. It's a positive. Am I correct? Or
Yeah, you meant isotope, not isomer.
right. So the 64 or the carbon 11 is the version. I think carbon is 12. Maybe wrong, but it's been a long time since I studied the periodic table. But I do know that carbon 11 is a positron agent. So these three are common. We include C11, but C11 acetate's been pretty much replaced by C11 choline. All of the rest of these are pretty much investigational. Let me back up one thing. F18 FACBC, this is the generic name. This is fluciclovine or Axumin, and we'll talk about that later. C11 choline, which a lot of you have had, and maybe you had to go to UCLA or Phoenix to a place where they had a cyclotron on campus because the half-life is 15 minutes. And it's FDA approved, a very good test. Logistics are incredibly complicated, and it's not widely available. And this is for evaluation of suspected recurrent prostate cancer. F18 fluciclovine or Axumin, which is the trade name, is pretty much replacing choline 11 because it is at least equal to the accuracy of C11, choline, and in some areas it might even be more sensitive. But it's in the same ballpark. The half-life is 120 minutes or maybe 110 minutes. It's widely available now, fortunately. There's another version of, so again, this is fluorine 18, which is a positron agent. The PSMA lesions can be attached to gallium-68, which is a positron agent. Gallium-67 is a gamma radioisotope. Gallium-68 is a PET scan. Gallium-67 is a gamma scan, which we don't use in prostate cancer. PSMA is widely available in Europe. It will be FDA approved in the United States. Anybody that does PET-CT for prostate cancer cannot understand why this agent is not FDA approved in the United States. It's widely used in Europe. It will be approved in the United States. And most people believe that gallium-68 PSMA and fluorine-18 PSMA will probably replace F-18 Axumin, which is really the only agent that we can use now. FDA is evaluating all these studies, but it won't be long. Okay, so right now, FDG, which is radioactive glucose, positron, this is what we use right now for everything other than prostate cancer because, I mean, you would think that prostate cancer would have increased metabolism and would take up glucose, but it doesn't. It's like 50-50. If you have an aggressive prostate cancer, it might take up FDG, which is again radioactive glucose. But it's a great tool for lymphoma, breast cancer, lung cancer, on and on. So it's of limited usefulness in primary cancer. We don't use it for prostate cancer. C11, PET-CT, choline, and acetate I talked about. The logistics are challenging because the half-life is so brief. Right now, this is best test we have for evaluation of recurrent prostate cancer. It's not approved for initial staging of recently diagnosed prostate cancer, and it's not approved for the detection of prostate cancer that has not yet been biopsied. It's not a good detection agent. MRI is better, a digital exam is better, PSMA is better. It's not good for detection. And then these are on the horizon. All right, this is just a brief slide just showing these agents all have different pharmacokinetics. FDG is the workhorse for non-prostate cancer. You know, you can see that there's some uptake in the esophagus. This patient had esophageal cancer. This is a C11 choline agent. A lot of patients have gone to Phoenix for this, but really no more. It turns out the liver is a physiologic agent. All livers are white. Cancer is white also. It's white on this scan, but we can flip it and make it black on white. In the United States, most folks interpret black on white. This is the pancreas, which is intensely physiologic with a Axumin scan, but is not intensely physiologic on either PSMA or FDG. So it gets kind of complicated. You have to know what normal organs look like and what abnormal tissue looks like. This is the only physics slide I'm going to show. The question is, well, why do these agents work? Well, this is an example of Axumin, which is fluciclovine, labeled to radioactive fluorine, F18. It's an amino acid transport agent. This is the cell membrane. This is a cell within any tissue, but let's just say it's prostate cancer. Fluciclovine crosses the cell membrane via transport. You can think of these little Uber cars or taxi cabs, whoops. They get into the cell, and because they're different than glucose or normal metabolites, which can leave the cell, which is normal. These are trapped in the cell because they're different than the normal agents. So every cell in the body is exposed to the radioisotope. That's true for bone scans, thyroid scans, liver scans, all tumors, and a lot of things that are not necessarily tumor. All right, so this is just an example of the gallium-68. It's a positron labeled to PSMA, which stands for prostate-specific membrane antigen. This is a scan done in Europe. Hopefully we'll be doing these soon. These have tremendous signal-to-noise ratio. I think we would all agree that these malignant sites are extremely positive compared to background, which is a great thing for radiologists and nuclear medicine experts. So these are bone mets, thoracic spine. This is a metastasis in a rib. This patient has an intact prostate gland. I don't know how this patient was treated, but there is, you know what? There's no brachytherapy seeds. There's no metallic seeds, which they need for brachytherapy and radiosurgery, SBRT, CyberKnife, it goes by many names. So since this was in Europe, it's probably a staging exam. And so this is the prostate cancer in the right peripheral zone. These are metastatic nodes. This is, you might say, well, how about this one? That's hot as anything. This is the bowel. Again, a lot of normal tissues take up these agents, and you just have to know what's physiologic, what's not, and you have a CT scan that helps you localize and conclude, well, this is just bowel. Axumin, F18 fluciclovine, Axumin, how many have had one? Okay, great. So if you had it in the United States, and if you didn't pay cash for it, and if you wanted it covered by Medicare or commercial insurance, which they should, as long as you've had a definitive treatment, either surgery, radiation, and usually androgen deprivation therapy, you qualify for an Axumin scan, and you don't have to pay cash for it. The liver and pancreas are just physiologically hot. The bowel is hot. The rectum is hot. This is bladder, rectum. We're down in the pelvis now. And in some patients, the prostate gland can be diffusely hot. So this can be challenging. Obviously, if this is all cancer in the prostate, this patient has a PSA of 40, 50. But in that particular patient, that's just physiologic activity in the prostate. And again, we call this a MIP, or a maximum intensity projection image. We stack all the individual images and we get kind of a whole body look. And again, pancreas, liver, normal. Bone marrow is normal. Muscle activity is normal. Salivary glands are normal. You might say, well, these images look quite a bit different than this image. That's because we take the PET images, we fuse them with the CT images, and the computer, we can select any color range that we want to. And so we have these beautiful fused images that give us the ability to say, well, where is the Axumin? And anatomically, we can document where it is because of the CT part of it. So if your prostate gland is still there and you've had radiation therapy, this is a small prostate gland. It's been treated. All of these are metallic beads that they use for localization, for brachytherapy or radiosurgery. And this is normal. This is the rectum. That's normal. And we see no hot spots in the prostate gland. And just remember, this is just one slice. We have a whole stack of slices from the top to the bottom of the prostate gland. This is a patient with castration-resistant prostate cancer, recurrent, with a rapid doubling time, a rapid increase in PSA, and the right side of the gland is normal, but there's a big recurrent cancer on the left side of the gland. And this patient, here's the grayscale image, and we can actually calculate how metabolically active this is compared to normal background. And this is all normal background, sacrum, whoops, rectum or sacrum, acetabulum, femoral head. This is a patient, let's see. Yeah, this is another patient in whom we highly suspect has recurrent disease. Same patient, he's had radiation therapy. The gland should not be this hot. There's a radiation localization seed. And this is bladder because sometimes the isotope is excreted in the bladder, but this is the left seminal vesicle and it's hot and that should not be, and we can actually measure how hot it is. So this patient has locally recurrent cancer in the prostate bed as well as disease in the seminal vesicle, and hopefully no other disease above this, i.e. the abdominal retroperitoneal or liver or lung or bone. This patient only had soft tissue disease. So depending on their radiation history, they can do a boost, they can do radiation therapy, they can do androgen deprivation therapy, they can get chemotherapy, they can get all of the things that I know nothing about, but are on the list for treatment options with recurrent disease. And this is the future. All these new treatments are designed for patients who have already had their prostate gland radiated, but have recurrent disease. Same patient, only this time with the MRI thrown in. This is a computer-assisted MRI. All these colors indicate increased blood flow. Here's the cancer in the prostate bed. Here it is because it's more vascular. Here's the left seminal vesicle, and this blue is on MRI, it's more vascular. And I actually biopsied both lesions. This was the central transitional zone lesion, and here's the guide. The thin black line is the needle. No question that this is in the lesion. This is a targeted biopsy. Dr. Cooper probably talked at length about this. And then I also did the seminal vesicle lesion. And here's the side view of that. The seminal vesicle is an ovoid structure and totally nailed it, and both were positive. This patient was prone, had an IV, conscious sedation, got fentanyl, which is a narcotic, got Versed, which is a minor tranquilizer, did not remember the procedure, had a few drops of blood afterwards, went home at 2 hours. Very well tolerated, not pretty. Well tolerated, safe, targeted, 2 needle placements. After I place the needle, I just rotate it and take multiple cores kind of around the clock. I don't know, I don't remember, but we've had many biopsies where the patient had a transrectal ultrasound guided biopsy, the blind 12 cores that missed the cancer because they really can't see it. So the MRI targeted biopsy will eventually become the standard of care. It is the standard of care in centers like Imaging Healthcare. It's now becoming the standard of care in many academic centers, and in Europe it's widespread. So this is good stuff. This is another, I put this case up because this is not fluciclovine, this is not Axumin, this is not the prostate cancer specific PET scan. This happens to be an FDG PET CT, the glucose sugar variety, because this patient has a very poorly differentiated Gleason 9, Gleason 10, high-grade prostate cancer, and this one did take up so this was an incidental finding. You can see the disease is extending into the seminal vesicle. This is disease in the prostate bed. Now, amino acid transport, Axumin, PET CT, they enter the cells of every tissue in the body. So you can identify other cancers, and every now and then we'll see another cancer. this patient had a negative exam. I'm not sure. He might have had recurrent prostate cancer, but because we scanned the entire body, we found a lung cancer. This is a large, unsuspected, non-diagnosed lung cancer, and because it's hypermetabolic, Axumin goes to other cancers, it goes to infections, et cetera, because this is a metabolic imaging study. All right, if you've had a prostatectomy, either open surgical or robotic, prostate's gone, actually much easier to image a patient who no longer has a prostate than a patient who has a prostate and there's normal physiologic activity in the prostate. Okay, I showed you that one case where the entire prostate was hypermetabolic. That's a pretty tough prostate to evaluate because it's either normal or the whole thing is cancer. I won't get into how we can make that differentiation, but I think the point is made. But if the prostate gland is gone, then any activity in the prostate bed is very suspicious. So this patient, this is the bladder, there's clips where the prostate gland used to be, and there's focal hypermetabolic activity right next to these surgical clips. So this is clearly a local recurrence. It's next to the bladder wall. The patient had cystoscopy. They saw a little bit of the cancer. They biopsied it. It was positive, but the cancer extended outside the bladder wall, and the patient, I believe, had already had external beam radiation to the entire pelvis. So the radiation therapist, the radiation oncologist, I read the PET scan. This is the beauty of being an interventional radiologist who does PET. I read the PET scan, and then we put him prone. I flipped these images, and I put using CT guidance, I put a biopsy needle right into the little nodule that was hot on PET, and I'm using the PET scan as my guide. I'm sorry, I'm so spastic. So I took a little piece of that. It was confirmed to be biopsy, proven cancer. And then I put 3 little gold seeds. This is just one of them. I put them, I kind of build a triangle around the cancer. And then since this patient has already had external beam therapy, the second time around, they can have focused radiosurgery, SBRT, CyberKnife, whatever. It's stereotactic. It only radiates the tissue, and that's what the treatment was. Lymph nodes, we always see metastatic lymph nodes, not always, but usually. So this patient has a high PSA, recurrent disease in the prostate bed, and then all of these are hypermetabolic retroperitoneal lymph nodes. This is normal activity in the liver. This is normal activity in the pancreas. And this is the aorta. This is the inferior vena cava, psoas muscle, pelvic bone, lumbar spine. So here's the node. It's hot. And this is just the axial slice. This is the coronal slice. So the computer's very helpful in localizing and confirming the location of these nodes. This was another patient who had only one hypermetabolic node. The pelvis was normal. This node was hot. No other disease. The radiation therapist has to know whether or not that node is cancer or is it a reactive node. So he was referred to me. This is just one slice with CT guidance, outpatient procedure. I put the needle in the node, and I used the CT to tell me, am I above it? Am I below it? Did I miss it? But, you know, it takes about 5 minutes to get this needle in place. And here's the needle before I hit the button and slice off a little tissue. And I take multiple pieces, and there was no cancer, and we concluded that it was a reactive node. When you get a virus, you get sick, your nodes in your neck get big, then they get small. These are reactive nodes, and it's treatment-related reactive node, benign. Axumin, again, goes to all tissues that are metastatic. It's pretty good with bones. There are some lesions. If this was a super white sclerotic metastasis, there's no PET in the world that will identify that. It just turns out that if a bone met is super, super, super dense, it can be falsely negative and you won't see it. But I think you can see that this metastasis, unlike the normal bony trabecula, this metastasis is faintly white on the outside and lytic or low density on the center. It's hot. The center of it is hot. The white part of it doesn't react, and there it is on the MIP. So this patient had an isolated, and we biopsied this, and so this was a skeletal metastasis. Axumin's not perfect. This is a nice example of a very, very, very dense lesion that we had old scans, it wasn't there. So we knew it was a positive scan. Here's the same cut on an Axumin scan, it's not hot. We did a sodium fluoride scan, which is a super duper PET bone scan, and it was hot. So then we know this is a cancer. Somehow I omitted the slide. On December 17th, Medicare no longer covered sodium fluoride. It was covered for at least 3 or 4 years. To everybody's disappointment and disbelief, the Center for Medicare and Medicaid Services did not approve it, and the approval process expired. Our hope is that someday soon they'll again approve it. So now it's either covered by commercial insurance or cash pay. Fortunately, this isotope is a lot cheaper now than it used to be. So the cash pay price is not unreasonable, but it's still a cash pay price. I mean, that's an inconvenience.
$1,400.
How much?
$1,400.
Right. Now, if you had paid cash 5 years ago, it would have been $2,300. But at our center, we're independent. We're not a hospital. Hospitals don't do well with cash pay patients. They don't know how to process it. Their prices are 3 times more than an independent non-hospital. Now, hospitals do great work. That's not an indictment. The hospital that I work at, they just can't deal with cash pay patients, okay? They're a hospital. They specialize in taking care of sick inpatients. They do some outpatient imaging, but centers like ours do outpatient imaging. That's all we do. We recognize that patients need imaging studies, so we charge them for the isotope and a little bit more to interpret it, and that's why it's $1,400 instead of $3,000. That's my one and only political statement, sorry. This is a patient who had a sclerotic lesion. The PET was warm but not diagnostic. Radiation therapist had to know, so referred him to me. I flipped him over. We gave him a little sedation, local anesthetic, didn't feel a thing. I put my needle in, and the sclerotic lesion, I biopsied it. There's my biopsy track. It's pretty. This is an 11 gauge needle, but we use a 18 gauge needle for MRI guided targeted biopsies. This is an 11 gauge needle. It's bigger, even though the number is smaller. Those of you know the difference between gauge and size. It's 11 gauge needle. It's a pretty big needle, but I'm not going through anything that's unsafe. Just fat, muscle, and that's my core, and that was positive for metastatic prostate cancer. All right, that's it. Thank you very much.
Wow. Thank you very, very, very much.
All right, so I was a little long-winded, sorry. And it is Father's Day weekend, so I have 15 minutes.
Okay.
My boys are home.
Okay, great. I'll try to hurry along. Okay, and Field some questions for no more than 15 minutes.
All right,
Bill?
you had your hand up first.
Just a quick note, gauge is hard to understand unless you understand, it's a fraction of an inch. So 11 gauge is 1/11 of an inch.
Right.
And 18 gauge is 1/18 of an inch.
So this is the gentleman that informed me of the periodic table a little bit earlier.
So I can't, what can I say?
Very good.
Okay, who?
I have limited chemical knowledge, but I understand needle size.
Back
And
by the pillar.
believe me, I would put the right needle size in the correct patient in the correct location.
Speak
Thank you.
loudly.
You're Bill? Are you Bill?
I'm Bill.
Bill, thank you, Bill.
Yeah.
Sir?
Back there.
So as far as detecting prostate cancer, is the imaging more effective at detecting cancer that's a higher Gleason score versus a lower? So can you see 6 Gleason versus 7 or 8?
Okay, so I'm assuming that you're in the diagnostic stage pre-treatment.
Yes.
Okay. MRI is the best test we have for, I don't want to say diagnosis. It is a darn good diagnostic tool, but it's a great test for staging. The more well differentiated your tumor is, i.e. your Gleason score is low, the less the accuracy is. Although MRI's darn good, Acumen is not as hot. The higher your Gleason score means the more poorly differentiated your cancer is. 6-7 is obviously the threshold above which treatment is usually done. A Gleason 10 lesion will be that gentleman that had the radioactive glucose scan that rarely works with prostate cancer. His was a Gleason 10. His glucose took up the cancer. It normally doesn't. So it tends to be the worse your cancer is, usually the detection, the MRI, the Acumen, the nuclear medicine is more accurate. I hope that answers your question.
What associated with the same question, depending upon the results, can the same MRI be applied to whatever treatment is determined to be?
Excellent question. The answer is absolutely yes. Right. The radiation oncologist will refer a scan to a center that can easily assist them in fusing the MRI scans to their treatment CT. They fuse it. Their physicist does treatment planning in a three-dimensional sense. They use the MRI abnormality to do their stereotactic treatment contours, and they're rarely round, they're random shapes, so absolutely. We can take CT, not with prostate cancer, but MRI and the Acumen scan can both be used for treatment planning.
Then would the MP MRI add additional information, or is it a standard
What do you mean by MP MRI?
That's what we're talking about.
Yeah, no, every MRI now is MP, and yes.
Back over here, right here.
Yes, I heard in your introduction that you were with radiation in the Scripps Mercy.
I am a diagnostic radiologist and interventional radiologist at Scripps Mercy. When I'm at Scripps Mercy, I'm doing nothing but interventional radiology, doing biopsies, putting tubes in patients, draining, giving chemotherapy through interventional. The other 40% of my time is spent at imaging healthcare specialists, which is, 10 imaging centers all over the county. And I'm glad you asked this question because we have 10 centers. We do this high resolution MRI scan at 3 of our 10 centers, La Jolla, Tri-City, and Encinitas. We do our MRI guided targeted biopsies only at Encinitas. And that's because that's where our nurse is. That's where Dr. Cooper and I work the most often. And that's where we do our biopsies. Scripps Mercy Hospital actually doesn't have a PET scanner. We have a good MRI scanner, but just how things evolved in San Diego, because of my group, we were the first to get a PET scanner. Scripps Mercy has not gotten one. They're building a cancer center and they'll get one. Most other hospitals have PET scanners, but Mercy does not. It doesn't mean anything because there's a PET scanner 4 blocks from Mercy Hospital where the patients go. Yeah.
Because I'm in the scripts.
Right, that was just background, I'm sorry.
No,
Yeah.
Because they've got the new radiation center here at Scripps Torrey Pines.
Right.
La Jolla, okay. And that, I have a radiologist that came through Scripps that was referred to, and he's also here down in Scripps, La Jolla. But there's also a radiation oncologist. Now, we put together this plan and then schedule next week to go for the seed markers.
Right, the brachytherapy seeds, we call them fiducials.
Yeah.
They're gold, they're low-grade gold. I usually tell patients 4 carats, 6 carats, seriously?
Is that going to, when I'm going to go into this, the treatment that I have chosen is external beam radiation,
Right.
and it's going to be intensity modulated, and it's going to be image guided. Now, are those, those seeds are going to be somehow CAT scanned or something to be fused with the machine to do the image guiding?
Correct. The needles, the seeds were placed probably by ultrasound guidance, maybe. That's how they're often placed. The images were fused to a computer, the radiation oncologist. So the radiologist, like me, makes the diagnosis. They combine that information with your radiation oncologist. They fuse the images, they do a stereotactic treatment plan using those seeds because that anatomically allows them to dial in with the treatment plan so they can avoid radiating the colon, the small bowel, and all the other structures there. Excellent site. The work that's done there is done at other centers. That's a great site. I hope that answers your question.
Yeah, it does. You had asked the question a number of times, have they had any radiation oncologists here? And there's a bunch of names that went by. The
Right.
one that I'm talking about is, he's Tripuraneni.
Right.
He's the radiation oncologist.
Right.
And you see,
Yeah, there's a lot of organizations, a lot of groups all doing great work. North County, Central, South. Some are affiliated, some are not. That's a Scripps site. Complicated answer.
You mentioned high Gleason scores and high PSA scores. What are the generalized standards for low versus high? And also, with respect to radiation, and specifically the proton versus the generally accepted radiation, what are your thoughts on damage from the normal radiation program as opposed to the proton? And how do they utilize the mechanics of the radiation to identify if they've hit the different cells that are on the pancreas? Because obviously, I mean, not the pancreas, the prostate. So because the prostate will have cancer in various areas, as you pointed out.
Right.
So does it just generally bombard the whole area?
All right, so I was hoping I was not going to get a proton therapy question. Remember now, I'm a diagnostic radiologist. I specialize in 2 things: putting needles in people, doing diagnostic procedures, and I also do nuclear medicine and a lot of PET CT. So I'm not on the therapy side. I know a lot about therapy, but I do not. Proton therapy is still relatively new, and the experience results are different for different organs. So Dr. Kipper, I know him personally, he may touch on that. He's awesome. You're lucky to have him next time. Radiation therapists, radiation oncologists know a lot about that because they're treating prostate cancer. When to use proton therapy, which is protons, when to use radiation. And radiation, again, can be external, where the entire pelvis gets radiated and they attempt to localize it. Then there's stereotactic radiation therapy, goes by many different names, SBRT, CyberKnife. The generic name is radiosurgery. They use highly sophisticated treatment planning with fused images and computers. They claim, and I'm not a therapist, but they claim that their margins are 2 to 3 millimeters outside of the tissue they're treating. So the advantage of that is you can have a patient who underwent 6 weeks of external beam radiation and got the full bed, the full pelvis, including the bone, the bladder, and the bowel, even though those tissues were not as radiated as the prostate gland. Those patients can, so let me back up. Those patients can never have external beam radiation again because they've already had full dose. But those patients can get the focused radiation. Now, whether or not those patients can also benefit or will respond to therapy with protons, I don't know.
You did answer the last question, or the first question. That was, what is considered high and low? You have said tens and...
Oh, okay. The PSA question, for imaging, this is probably worth hearing. It turns out that the PSA level and the ability to detect recurrent cancer with either choline-11 or F18 Axumin or gallium-68 PSMA does depend on your PSA. The lower it is, the accuracy is not as good. If it's 0.1, 0.2, you're gonna pick up 50 to 70% of local disease. If your PSA is 2 or greater, the accuracy goes up. So it's a long discussion about which one is better at what PSA, but in general, the higher your PSA, the better the detection is.
Let's do one last one so we can get the good doctor over to see his sons.
Larry? How many PET CTs, whole body, over what period of time does a person have to start worrying about accumulated exposure?
Okay. In 2009, you all read about, or maybe a significant part of your portion of the audience read about the famous Cedars-Sinai case, where they were doing a CT scan of the head. The patient had a stroke, and they had a relatively new perfusion CT protocol that's now in general use. Somehow there was a technical error, and instead of scanning the entire brain, this is, by the way, this is not confidential. This was international world news, and a lot of you have heard about it. They ended up scanning the same slice over and over and over and over again. So overall, the radiation dose was not significant, but it sure was significant to that one slice. Patient lost his hair. There's a lot of issues. I don't know how that patient's doing now, but he's probably doing okay. But that was a serious test. That was the wake-up call for radiation dose reduction. And I'm proud to say, being an independent imaging center, we were on it. So we developed BMI protocols. If your BMI was under a certain level, we dropped the radiation levels. So there's all kinds of things you can do to minimize radiation. PET CT scans, you get radiation from two sources. You get it from the CT part, and you get it from the injection of the radioisotope part. There's weight-based protocols, particularly with children. That's the group that are the most radiosensitive. So there's definitely a weight-based dose schedule. The smaller the patient, the smaller amount of radioisotope you get. Adults more or less get the same dose. The good news is, okay, the CT part of it is super low dose because it's not a diagnostic scan. You don't have to increase the kVp and the MA, the current, to diagnostic levels. You can do it at low radiation because the main point is to make the PET images look good. We always look at the CT images. We look for lung nodules, bone lesions, aneurysms. We look at them, but the radiation dose from the CT part is like background. Background radiation from living in San Diego for a year, okay? Unfortunately, the PET part of it is a higher dose. I don't say unfortunately because it's a great test. The good news is it takes 30 years, you know, some people say 20, some people say 40. It takes 30 years to develop a radiation-induced malignancy, and that's what we're talking about. If a little kid gets a CT scan once a week for a year, the risk of that patient developing a cancer in their lifetime, remember now they're 9, goes up. But it doesn't go up by 50%. It goes up by a very small amount. So, everybody takes radiation seriously. All the academic centers everybody is doing dose reduction. But I got to say, the academic centers were the last to do that. Now, why is that? Well, they have residents and fellows. They do lots of phases. They're learning, and it's a bureaucracy. It takes a long time for things to happen. They do great stuff, but dose reduction was the last thing they got into. Everybody gets a scan now. I can't answer your question about how often you need a scan. There's a lot of oncologists and a lot of radiation oncologists, a lot of urologists that need a scan done at 3-month intervals for X amount of time, and then maybe every 6 months, and then once a year. In my opinion, the radiation part of that is insignificant because it takes so long for there to be a detriment. Those are general comments, but I hope that helps.
Thank you. Thank you very much. Thank you, Jim.
All right. Thank you.